Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
Let's take a first case of a 60-year-old woman with a good performance status and a remote prior smoking history, not a lot. And she has a lung adenocarcinoma, metastatic disease to the liver and an adrenal lesion. And the initial testing shows that she's ALK positive. She has an ALK rearrangement. What is your go-to approach right now, just for the straight pitch down the middle, ALK positive first line treatment today? Suki?
Yeah, so my first drug of choice for this patient you just described would be alectinib.
Mm-hmm. Okay, Alecensa. And just to clarify, we'll generally use the marketed names just so that they're accessible to the patients, or introduce them together. But alectinib or Alecensa is the one that you would favor. Why is that?
So I guess right now we have essentially 4 ALK inhibitors that we can choose from that are FDA approved. So alectinib, brigatinib, ceritinib, crizotinib. Mm-hmm. And in terms of the 2 trials that have compared an ALK inhibitor to an ALK inhibitor, we have alectinib and brigatinib. And alectinib right now has the longest sort of follow-up in terms of efficacy. So alectinib, was studying the ALEX trial against crizotinib and showed quite a striking improvement in progression-free survival compared to crizotinib. And that data, I think, has been finalized now at ESMO this year.
Mm-hmm. So again, this importantly is a head-to-head trial. Xalkori or crizotinib was the first of the ALK inhibitors we had. We were happy to have it when we did, but since then it has been eclipsed in efficacy by the second generation agents. Alecensa or alectinib is one of those. And in the ALEX trial, which was a global phase 3 randomized study where half the patients got alectinib, half got Xalkori, crizotinib, it crushed crizotinib in every way. Progression-free survival, I think a little better response rate, and well tolerated as well. Much better activity in the brain. Hasn't shown a survival difference, so that's something that may be hard to do when we're talking about the fortunate situation of people living so long that they get the benefit of lots of opportunities. But you also mentioned that there are other second-generation ALK inhibitors. Brigatinib or Alunbrig is one. It's actually not FDA approved yet in the first-line setting, but it is approved second-line. It has good data, but it hasn't been studied as long, or we don't have data out as far. Jonathan, where do you see the landscape? Is alectinib, Alecensa the clear treatment of choice here, or do you think that there are a bunch of choices that are pretty comparable?
That's a great question. I think, my practice is similar to Dr. Padda's in that I generally use alectinib, Alecensa as first-line treatment, and it's been as Jack talked about, it's a game changer. Mm-hmm. Progression-free survival, on the order of about 3 years versus about 10 months with crizotinib. But brigatinib, although you mentioned it's not approved yet, looks comparable. Mm-hmm. The follow-up is not as long, and in the New England Journal they had a major paper when it was presented World Conference of Lung Cancer. At that time, median PFS was not reached versus crizotinib at 18 months. Progression-free survival, the time it took for the cancer to start growing again, and so it looks, that's another compelling potential first-line ALK drug that's not yet approved, but looks comparable. Lorlatinib is a third-generation ALK inhibitor that's being studied compared to crizotinib in the first-line setting. It's now approved after progression on prior ALK drug, and that also we eagerly look forward to that data as well.
So we have several ALK inhibitors, but you have to pick one in the first-line setting. With Alecensa looking so strong, what do you need to see to decide to use Alunbrig, brigatinib, or lorlatinib as a choice? Does it have to be way better tolerated, or when you're out to almost 3 years before the cancer progresses with the drug you have, pretty hard to improve a lot on that?
Yeah, I mean, it's in terms of brigatinib, Alunbrig, being a first-line option when you already have alectinib that's approved, it's a very good drug, but you would have to see, I think that progression-free survival benefit by a pretty decent amount to switch. And I mean, we always talk when we talk as lung cancer docs, we talk about sometimes, comparing one trial to another, there's all kinds of statistical pitfalls and so forth. But, if you compare one to the other and see at least a multi-drug, multi-month benefit of several months or more, that's something that may be compelling in terms of a first-line option. I think the other thing would be, when the overall survival data eventually does mature, where we can see that if there was a survival benefit overall where patients were living longer in one versus the other, that may be something too. But I think it remains yet to be seen.
I think it is. It's difficult when you're talking about people who have the fortunate problem of living so long with these that it's really hard to tease apart what is caused by the first treatment versus everything that follows. But
I agree. I think it's always going to be a balance between benefit and risk. And what Alecensa has is kind of that nice benefit. Of course, any drug has side effects, but, at least in my experience, the side effects have been relatively well tolerated, as best as my patients tell me. And in order, I think, for brigatinib to sort of take its place, like Dr. Riess said, essentially it would have to have a significant numeric improvement in terms of that time on treatment, right. Time to progression, and like a significantly better safety profile, which from the initial data, I don't think we at least see that.
Right. I think alectinib is pretty secure in its place right now, given how well it has worked. So that's a hard thing to topple.
I would say it's nice to know, though, that there's a potential other option. Alectinib, Alecensa is generally very well tolerated. But, there are instances in certain patients where certain things like liver function abnormalities or
develop edema.
And it's nice to know that you could feel, with the brigatinib and Alunbrig data, you feel comfortable saying, okay, well, we can make this switch and we feel comparatively comfortable. So that's not that many patients, but it's, it's something. It's nice to know.
Yeah. It's always good to have more options.
I think the other thing, just to, if you don't mind, is
I do not. No.
it's just that both of these drugs have fantastic activity in the brain, which we know is very important. Because sometimes for our patients, if our patients present with multiple brain metastases and there's not really a local option for radiation, it's nice to know that we have potentially two options that have great activity in the brain, because we want to do everything we can to avoid, whole brain radiation for these patients who may live a very long time.
Thank you again for joining us. podcast was made possible by the generosity of sponsorship from our friends at Lilly, Novartis, Takeda, AstraZeneca, and Exelixis. Please like and follow us on Facebook and Twitter. Send us feedback, share your story, donate and visit us for more information at cancergrace.org. Thank you for listening.